as Mary says, I'm going to try and tackle prognostic markers in MS. And these are my conflicts of interest and disclosures. And I wanted to tell you a little bit about myself and our team, because and why we get asked to talk about things like this. So we look after a population of about 1.5 million in the corner of Wales. For those of you who don't know where Wales, or the geography of Wales, that's the bit that we kind of look after down there. We have 4 structures in the department which provides our service. One is the Helen Durham Centre, which is the NHS Centre for MS, so it comprises of about 20 or 25 or so people. We have quite a well-known, I think by now, clinical tool or database which registers all of our patients, and actually has done since 1985, when Alistair Compton started this off. And the actual study that accesses that data is called Snowdonia, and parallel to that we have what's called the Welsh Neuroscience Research Tissue Bank, which holds samples longitudinally on all of these patients. So far we've registered about 4,000 patients. We see about 100 to 150 new diagnoses a year. We try to see and assess patients every year. We have this extensive database called Patient Care. We have about 100,000 samples in our biobank. And what we're interested in is long-term outcomes and biomarkers. And the plan really, or the concept, is that we're trying to provide a history of the patient from diagnosis to death, with all of these aspects of patient-reported data, clinician-derived data, MR, genomics, demographics and biological samples as a kind of a library for people to access and explore things like potential biomarkers and long-term outcomes. So that's our basis, and that's our expertise, if we have any at all. So I think the important thing to understand is that despite all of these advances in the pathophysiology of disease, so understanding the role of particular cells, the huge amount of information now available from genomics, and some phenomenal imaging advances, our ability to predict short-term and long-term and treatment-modified outcomes for individual patients in MS remains very limited. And it's the individual patient issue that's perhaps the most challenging. So if we think about biomarkers, it's perhaps important to understand there's a range of biomarkers that we potentially can use. So for instance, the susceptibility loci from the genomic studies will give you susceptibility risk, but there are also diagnostic biomarkers, monitoring biomarkers, pharmacodynamic response markers and safety biomarkers. But the ones that we're really missing in MS is our ability to prognosticate for individual patients, but also to predict how they might respond to a particular therapeutic strategy. So we're not very good at that at all. So we have some particular challenges in multiple sclerosis. So it's perhaps important to remember that in terms of the background of the disease that we're trying to deal with, it remains a syndromic diagnosis. There's no test that we can do specifically that gives us 100% sensitivity and specificity. And it has an incredibly variable outcome. So that undeniably there are some people, for instance, who spend almost all of their lives, 30 years or more, without almost any disability relating to MS. They're a very small proportion, but they do exist. And on the other hand, there are patients with Marburg phenomenon who develop a very severe type of disease and die, and everything else in between is seen. It's almost certainly the case that we're not dealing with one disease, but we're unclear about the classification of that, although there are a number of pathological theories about that. And now we have a huge number of therapeutic options. I can't even remember how many there are. Is it 14 or 15 now? And all of them, a lot of them, there's an increasing range of mode of action and also efficacy, which comes with its potential side effects and risks. And I think it's fair to say now that adverse effects of treatment are really pretty common. So our main unmet need is prognosis, both individual prognosis and response to treatment, which might reflect an underlying biology, for instance. So it's perhaps worth thinking, what makes a really good biomarker? So if a good biomarker in MS would be something that's accessible. So not only could you take a sample and retake a sample easily without it being too invasive, so in other words, lumbar punctures, most people wouldn't say are a particularly accessible source of a biomarker fluid. But also, the actual technology associated with the biomarker needs to be accessible. So, for instance, neurofilament is really measured in plasma using a Simoa machine, of which I think there are 4 or 5 in the country. So that's not going to be widely accessible in terms of managing the general population. So it needs to be sensitive and specific. It needs to be reproducible. So you need to be able to do the test and do the test again and get the same results. It needs to be standardized. So generally, there has to be a standard which people stick to. And it needs to be informative on an individual level. And I'll come back to what level that might be. But if you remember that figure 10, that might help you going forward. So what are our potential sources of biomarkers? Well, we have historically looked at clinical features. In fact, it's been very difficult to put a model together, but I think most clinicians will kind of look up a patient and intuitively think about all the things that might give them good or bad prognosis and make a judgment. And that's some of the basis of what we select treatment on. And then there's obviously MR scan. There are increasingly a number of fluid biomarkers that we're considering, and lots of them, and some of them have become very trendy, very recent, and also genes have perhaps, although thought of as enormously promising at the beginning, perhaps haven't been as productive as we thought they might have been. So it is true that we already use a lot of biomarkers in MS. So for instance, if brain volume provides proof of concept in the early clinical trials. So if you use a phase 2 study now for a DMT, people often use brain volume change as a surrogate marker of outcome. So we monitor disease with MR scans and the number of T2 lesions and GAD-enhancing lesions that people see. We now expedite disease detection in the form of oligoclonal bands, and I'll come back to that in a minute and why that's taken on a kind of a different flavor recently. We try to predict clinical outcome with numbers of T2 lesions on baseline MR scanning. We can use neutralizing antibodies to predict response. And we can predict treatment adverse events, so JC virus T. So I think you're going to hear more from David about that, and you heard from Paul last night about that. So we already use a range of biomarkers to manage MS. So the next thing perhaps is to understand a little bit about prognostic models. And I know this is a bit complicated. It's complicated for me as well, but just to get the language right. So most of the modeling studies and the outcomes we talk about relate to Kaplan-Meier curves, which is the time it takes for a group of people exposed to a particular event to reach a certain disability milestone. So we talk about Kaplan-Meier curves and time to disability milestones, for instance, EDSS-6. We then have something called a Markov model, which people use, like NICE use for economic modeling. And it's the chance of moving from one disability state to the next. So in terms of NICE, that might be, what are the chances of you going from EDSS-4 to EDSS-5, for instance. So that's what all of the drugs, the modeling for economic viability are done by NICE, are currently based on that Markov model. And then we have disability trajectories. And this is a really common one that people have used in the literature, which is the MSSS, the Multiple Sclerosis Severity Scale, which just gives a normalized range of values for what people might expect to see in terms of disability over the course of their multiple sclerosis. So it's disability divided by time, as it were. And that's quite useful for treatment planning. And just as an example of that, this is our system, our clinical tool that we use. And so for this is, for those of us from Cardiff in the audience, we'll recognize the patient simply from the profile. But this was a patient where all of our disability scales are put on the background in terms of centiles. So this is available, this is a kind of summary of all of our patients, and that's the median. So this is a patient who rapidly went up to EDSS 8, so crossing all of the centiles, and then there was sort of a range of interventions which then return them to a more normal disease trajectory. So it's a visual way of looking to see how a patient is doing compared to their peers, and it informs us a little bit about how we can intervene. So just to begin with some basic stuff. So clinically isolated syndromes, which we still see, although much less than we used to for reasons which I'll talk about. They tend to present around the age of 30 with optic neuritis, brainstem lesions, spinal cord, and so forth. And their oligoclonal prevalence, band prevalence, is about 60 to 70%. So the rate of conversion is similar across the sexes, but the conversion rate is influenced by age in the sense that if you're around 30 and you're a female and you've got an episode of optic neuritis, then that makes you much more likely to develop MS, for instance, than a male who might present at the age of 60. But the two things that predict conversion the most are the presence of oligoclonal bands and your baseline changes on your MR scan. And people have looked for various other things, and maybe there's an effect of vitamin D, but in general, there haven't been anything else that's reliably predicted a conversion to clinically definite multiple sclerosis. So baseline MR scan and conversion to clinically definite disease. And this is why the clinicians and the radiologists will often count the number of lesions when they see somebody with a clinically isolated syndrome. So the more lesions that you have, the more likely you are to convert to multiple sclerosis. So if you've got a normal scan and you've had an episode, then you've only got a 9% conversion rate over 15 years. But on the other hand, if you've got more than 9 lesions, your chances of converting to MS are over 80%. So that's an important baseline measure that we can all look at. We can look at a result on the scan and we can make a judgment about how likely they are to convert to MS. It is also true that if you have infratentorial lesions, then you're much more likely to convert to MS with a hazard ratio of about 3 times more common. So you need to count the number of lesions, and then you need to ask yourself roughly, where are they? So the oligoclonal band issue has made a big difference to diagnostic criteria recently, and this is the reason for it. So this is an odds ratio, a cumulative odds ratio of all of the studies looking at clinically isolated syndrome and their chances of developing clinically definite disease, depending on whether they're oligoclonal band positive or negative. And the cumulative odds ratio is about 10. So this was the reason why it informed, and I don't think it was a universal thing, I have to say. I understand it was slightly controversial, that now if you have one clinical attack, you have dissemination in space, so you have a number of T2 lesions on your MR scan, and you have oligoclonal bands, we can now make a diagnosis of multiple sclerosis on the new McDonald 2017 criteria. And perhaps the interesting thing about that is that it was slightly controversial. The odds ratio was around 10. So 10 perhaps is the threshold at which people are taking a piece of information seriously enough to make individual predictions. So if you remember that number 10 going forward. So the baseline MR characteristics also predict some future disability. So if you have infratentorial lesions, you're much more likely to accumulate disability. So this is one of those KM curves, and this is the chances of you having an EDSS of greater than 4 over time, over 3 over time. And people with infratentorial lesions are much more likely to develop disability early on that basis. So where the lesions are also predicts how disabled you're going to become. This is a very recent study last year from the Queen Square group looking at their historic cases of clinically isolated syndrome, who they scanned on 3 different occasions, and demonstrating that baseline GAD lesions, if you have more positive GAD lesions at baseline or more spinal cord lesions, that it increases your likelihood of developing secondary progressive MS, which obviously is associated with a degree of disability at 15 years. So if you have no GAD lesions and no spinal cord lesions, your chances of developing secondary progressive MS at 15 years is about 1 in 20. But if you do have those characteristics, then your chances of developing SPMS at 15 years is nearly half. So remember those odds ratios. So it was an important enough observation to get into brain. It's certainly valuable on a population basis, but remembering that kind of figure of 10 that you need to get to, it maybe is not it influences your decisions, but it's not definitively helpful, shall we say, in managing an individual. So in terms of clinical features, we get most of our prognostic information from a variety of what they used to call natural history studies and now have kind of transformed into what we now know as real-world data, which has had a huge influence on all of the conferences that we go to at the moment. And those real-world data studies, now everybody know about MS BASE and the UK MS Register and the clinically isolated syndrome cohort that I've just talked about, and groups from Spain which have been very influential, and we have our own data as well that has been useful. So this perhaps is a kind of broad summary of the things that you ought to take notice of, so the things that you need to list down when you have a patient who first presents with you and you're trying to determine what their future is going to be like. So people who have a younger age of onset are said to have a better prognosis. There are some caveats to that, which I'm going to go into. So women, as in many things in life, but not all, tend to do better than men. If sensory onset, so those people without a sort of fixed deficit afterwards, particularly, do much better. And this has been a very interesting one that's been had a bit of attention recently, and we recently published a paper in neurology with a Canadian group showing exactly the same effect across both populations, which was that your social class had a very significant effect on your long-term outcome. And that's interesting because it rather indicates that there are quite a lot of environmental modifiers that can alter how people do in the future outside of drugs or other aspects of disease. So long inter-attack interval has a good prognosis, at least of disability early on in the disease. And then there's this rather classic thing of the difference between relapsing and progressive disease. Optic neuritis tends to have a better prognosis. Multifocal onset, so somebody with an optic neuritis and a hemiplegia, for instance, at onset would have a worse prognosis. And I've talked a little bit about complete and incomplete recovery. But most of these features have hazard ratios of about between 1 and 3. So remembering back to what you really need to kind of inform you. Excellent. Thank you for that. I'm glad to hear about your phone. So, and just in case you want to know, so each one of these will have hazard ratios between 2 and 3 or so. And the hope is that you might hope that they would be additive. So somebody with relapsing disease with a long inter-attack interval would have an additive hazard ratio, but that's not the case. So there's a lot of overlap between those features, which don't allow you to put together a model which has a kind of a predictive value, which is kind of more than an odds ratio of 10 or so. So I put this in not really necessarily because it's related to biomarkers, because I think that there's some important information on there which you will all want to know for the future, for this year, about secondary progressive MS. So one thing is that this is a bar chart of all of our patients on our system with their disease course according to their disability. And the important thing, and obviously defining whether somebody has progressive or secondary progressive or primary progressive disease or relapsing disease is obviously important prognostically. So it's one of the classic prognostic markers that we use to determine outcome. But the important thing here is that if you're making a diagnosis of secondary progressive disease, for instance, with an EDSS of less than 3, you need to be very cautious about that. I'd worry that diagnosis was correct. And similarly, if you make a diagnosis of primary progressive disease with very low EDSS values, then you probably should be concerned. But in terms of, and this was really just for planning, given what's going to happen this year, is that we looked at all of our core data set, which is about 2,000 patients, and about 11% have primary progressive disease, 90% have relapse onset. And so this is perhaps the important figure that you want for your planning for various drugs, oral drugs that may come in the next year. So about 40% of our patients have secondary progressive MS. And one of the challenges I think we're going to have is to define the onset of secondary progressive MS in our population. And you can do it either by clinicians making a judgment about it, or there's a very formal way of doing it, which was defined by Embase and published in Brain and has those characteristics. So what difference does it make if you have primary progressive or relapse onset MS? What sort of disability differences are we looking about? So these are from the Kaplan-Meier curves from our data set, looking at primary progressive versus relapse onset patients, and their time to disability milestones for primary progressive disease, so EDSS-4, so mobility differences, 6, walking 100 meters with unilateral support, and 8, wheelchair dependent, is about half of what we see in relapse onset patients. So that's the kind of difference in terms of prognosis you're ascribing to your patient if you make a diagnosis of primary progressive versus relapsing onset patients. But in fact, I think that we all ought to be moving on from that now, and I don't know how many of you use this classification now. Have any of you seen this, or are you aware of it? So hands up who's aware of this. So a minority. So can I persuade you all then that when you're classifying patients going forward, that you probably shouldn't be using necessarily simply primary progressive, secondary progressive, or relapse onset disease, but we need to think about this, which was published actually some time ago now, so in 2014, where we determine whether patients have CIS and whether active or inactive, and whether they've got progression or without progression. So those are the 3 things that you need to be recording on your patient in order to classify them. That's certainly what we now do and have done for many years, and if you can look it up, and I think that it's going to be an important issue going forward, and I think all of the epidemiological data we had on prognosis relating to disease course is now going to change, and we're going to be thinking more about whether they've got relapsing disease and whether they're active or inactive, and how that determines prognosis. But that data really isn't available now at all. So age is perhaps the most important determinant of prognosis that we know about. It probably relates to the fact that comorbidities have a negative effect, that with increasing age, patients have a much more limited recovery from relapse because of plasticity and reserve. But there are some important aspects to that. So these are Kaplan-Meier curves, EDSS 2-8, or primary progressive versus relapsing disease. So this is the curves from disease onset, okay? So from disease onset. And you can see that patients with primary progressive disease do much worse than those patients with relapse onset disease. But that's the duration from disease onset. But if you say, well, actually, how do they do compared to age? So if you just simply say, what age do they develop the milestone at? Then actually the disability curves between relapsing disease and progressive disease are almost identical. And that's been one of the reasons why people have, including myself, have said, really we're not talking about different diseases here. Clinically, it's the same disease. It's simply that people identify the problem later. But one difference to that is about pediatric onset multiple sclerosis, or so-called early onset MS versus adult onset MS. So it's often said that people, when they get the disease very young, they tend to do better in the sense that they take longer. This is another KM curve, so the dotted line is the pediatric cases. They take longer to get to disability milestones. But if you look at time to disability milestone relating to their age only and not their disease duration, then actually they do a lot worse. So perhaps that's one reason that although we tend to be very cautious with pediatric onset patients in terms of selecting treatments, it may be that we need to actually flick our switch a little bit and actually be much more aggressive than we have been in the past, because overall they have a worse outcome. So the other thing that we often look at, and is obviously part of the criteria for determining treatment in MS, is the number of relapses that people have early in disease. And if you have a lot of relapses, then you have a much greater chance of acquiring disability in a shorter time than somebody who has the occasional relapse. So that's important. And that's the number of relapses in the first and second year and the time it takes to get to a significant disability milestone. So that's one of the reasons why NICE and so forth look at the number of relapses that people have, because they tend to have a worse prognosis. But you might think, and we go on monitoring relapses, don't we, through the entire disease, and we make judgments about changing treatment on whether people have relapses not only early in disease, but also late in disease. But in fact, the evidence for the number of relapses later in the disease causing future disability is actually much less. So the emphasis should be on how many relapses have you had in the first 1 to 3 years and the inter-attack interval. That's the prognostic value of it, not necessarily, in terms of disability at least, or fixed disability, it's not how many relapses they have later in their disease. So the other one that we commonly use is the brain MR scan to monitor MS, and the important thing here is early interval change. And there are a lot of studies now which have demonstrated that if you have active disease over a short period of time from baseline, so these are the criteria, these are the times over which the studies are done, and these are the sensitivity, specificities, or odds ratios, showing that if you have a lot of disease activity over an interval, then your likelihood of acquiring disability or your likelihood of having relapses is greatly enhanced. And again, that's one of the reasons why NICE uses these kind of criteria to determine the levels of treatment or accessibility to treatment. And I think that controversially, it may be that when we're making decisions about long-term treatment of the patient, it may be that perhaps all of our patients should have an interval scan in order to determine treatment, and either waiting for a short period of time while you acquire that information or putting them on a low efficacy treatment until you actually have the results of the interval scan actually might provide some considerable longer term benefits. And so certainly in our unit now, it is pretty standard to have an interval scan, a short interval scan, in order to guide treatment decisions. But I don't think that's a universal thing, and obviously it depends on resources and so forth. So the other bit of information that came out again from the group in Queen Square looking at their CIS cohort, which was 178 patients, is that if you had short interval new lesions, either GAD-enhancing lesions or new lesions on your spinal cord, then your chances of developing secondary progressive MS was much greater. So this wasn't only just the baseline, this was what was the change. So change in scan made you much more likely to develop secondary progressive MS. So this is just as a kind of a summary example. If you've got no baseline GAD lesions and over the 1 and 3 year interval scans, you don't get any new lesions, then your risk of secondary progressive MS at 15 years is 3%. But if you get 2 baseline GAD lesions on your baseline scan, and then you start acquiring new intertentorial lesions and new GAD-enhancing lesions, then your risk can be up to 85%. So it predicts how badly people are going to do, but it's a short interval. So the short interval scan determines how badly you're going to do. So perhaps this is a summary of what roughly we do, but I know that there's a wide range of opinion, and some people have absolutely no tolerance to relapses or new lesions on the scan. I think there's a certain illogicality there, if I'm honest. I think that it really doesn't make sense, and if you followed that logic, then you should start everybody on high efficacy treatment, and that's another argument. But if you've got no clinical or radiological MS activity, then we continue on the current DMT. If we have only clinical or minor to moderate radiological activity, then we have a short interval reassessment. But if they have clinical activity and radiological activity, then we consider escalation of their disease-modifying treatments. I think that's broadly what most people do, but I think that obviously it's the bit in the middle where people have different levels of tolerance, which I think vary considerably and for which there are no standards, and I think it would be very nice to develop some standards going forward, but that's not available currently. So with all of this, and our kind of intuitive idea of identifying prognostic features and then maybe deciding on various levels of treatment, do we actually make any difference to prognosis of patients with MS depending on what DMTs we use? So this is a comparative group showing patients receiving beta interferon compared to those who are untreated, and it does seem that their major disability milestones are significantly delayed. And that's also been supported by some subsequent work on that, and another study which has demonstrated that the chances of reaching EDSS-6 by age 50 pre-2000, so pre the age where we really started using disease-modifying treatments in significant numbers, was considerably worse than post-2000. So I think there is some epidemiological population-based data that we are making a difference to the overall disease trajectory of our patients with MS, but it may not be the kind of level that you had expected it to be. And the Europeans would look at us in the UK and say, well, actually, one of the reasons why that's the case is you're not treating enough patients. So the treatment rates in America, for instance, are 85% and 90%, and I think that the treatment rates in the UK, as I understand from a recent MS survey, was around 50% or so. So it may be that there's still, some of that is access to treatments and early intervention as well. The other really two interesting papers, which we were both involved in to an extent, was the differences between induction and escalation treatment paradigms. So this was a study that we did in Cardiff, where we looked at patients who had the very worst so we selected the patients who had all of those worst outcomes that I've talked about, and we started them on a monoclonal therapy. So we had, and that was their first treatment. So it was their first DMT given to the very worst patients. And we expected them, because they've got all the worst prognostic factors, and even though they started early on monoclonal antibody treatment, that they would do worse. So they represented perhaps only about 10% of our incident population. But the surprising thing was that they all did actually much better than the people that we thought had more modest disease, who we started on a lower efficacy treatment. And there are two potential explanations for that. One is that if you treat somebody very early and very aggressively, you give them a biological advantage, which you can't regain if you start treating them later. So that may be the case, and that's one of the drives for our shift to more high-efficacy treatment earlier in disease. But the second thing is that we're really not very good at monitoring patients, and we don't take the hint when somebody has some modest disease activity to actually escalate them in an early way. And some of that was examined in a paper published in JAMA, which looked at the M-based data together with data from Cambridge and Cardiff, published by Will Brown, who looked at what the effect was on secondary progressive MS, depending on what drug you got and how early in the disease course you got it. And there was a significant delay to secondary progressive MS if you were treated with a DMT in the first 5 years, So maybe that should be an aim for us all to get, if we're going to start treatments, treat people within the first 5 years. And that effects were much more pronounced if you gave them a high efficacy treatment within the first 5 years. So you seem to be able to modify the onset of secondary progressive MS if you treat people early and very aggressively. And again, it kind of informs the discussion, and that's why people are talking so much now about, early treatment, time is brain, starting them on early as you possibly can. And there is some now real-world data to suggest that really does have an effect. So lastly, I just want to talk a little bit about understanding fluid biomarkers, and it's a really complicated subject. I don't expect everybody to remember all this in detail, but perhaps the thing to do is to think about biomarkers being in different compartments. So we talk about inflammation, axonal and neuronal loss, glial activation, and mitochondrial dysfunction. So those are the kind of broad categories which people have looked at biomarkers. These are all the biomarkers. Don't remember them all. But the important thing is that none of them, despite papers being produced on all of them, are used in general clinical practice. And that's because they don't pass those tests that we talked about what was a good biomarker in MS at the moment. The nearest to it is neurofilament light chain, which is a skeletal protein in the axon, which you can measure in CSF and serum. It goes up after a relapse. It correlates modestly with EDSS. And there are some group-wise, so if you look at a whole population, there are some indicative features of high and low neurofilament. And there does seem to be some benefit of serial sampling, and some really important work came out of America recently with looking at combined outcomes of all the papers, of all the treated cohorts. But, and this is my opinion, because I know that some of you will be using neurofilament if you've got a Samur machine in your department. The problem with it is there's no accepted normal range. The technology has limited availability. It has a very modest individual predictive value. And the question that we don't really know is actually whether it adds any value to all of the existing markers like MR that we currently use. So what's the future of MS? Well, hopefully it's a form of personalised medicine where we have detailed clinical profiling and MR profiling, both at baseline and short interval, to inform later prognosis. I think that there's still some possibilities of developing genetic profiling which predicts outcome. And I think we're probably going to use combination fluid biomarker panels using combinations of axonal loss, inflammation, glial markers and so forth to tell us a little bit more about the underlying biology of disease in an individual. I think perhaps if you're going to talk to your patients, or as a summary, perhaps we need to remember that demographic and baseline clinical features have a low impact, oligoclonal bands have a medium impact, MR scan is perhaps the most high impact determinant of short-term prognosis. And I think a combination model of all of these things is probably what we're going to head for. But if you want to tell your patients something, then I'd say just be very careful about emphasizing baseline prognostic indicators. I'm coming back exactly to what Mary said right at the beginning. That look at early interval change is perhaps the most important thing. So how quickly do they change over a short period of time early on in the disease? But we do seem to be making a difference, which is encouraging. So that's it. So thank you very much for listening. This is the Cardiff team that have done almost all of the work, and I've done almost none. So thank you very much.